valuable for everyone as we discuss kind of these topics. Over the next hour, I'm going to be talking about the Epilepsy Monitoring Unit and the kinds of workup that we do at a Level 4 Epilepsy Center. But before we go into that, I'd like to start with just talking about a few definitions, make sure we're all on the same page. And I think the first thing we really need to understand is what truly is epilepsy. And then once we get to that point, let's talk a little bit about what is drug-resistant epilepsy or refractory epilepsy. Those have been discussed a little bit in prior talks, and I'll add on a little bit more information about those. Once we get to that, then we'll start talking about the different types of testing that we do. I'll focus first on cases of refractory epilepsy. I apologize, I have an adult bias. A lot of the patients that I see are adult patients, but I think a lot of the tests that I mentioned are relevant for the pediatric population as well. And then finally, we'll switch into some more special circumstances. So I want to make sure we touch about some of the special surgical testing we do, genetic testing, and then autoimmune testing. And then finally, I'll just talk a little bit about the next steps. And there's a broad kind of group of what those next steps are, but we'll kind of go through those. So to start off with, let's define what seizures are. And seizures are abnormal synchronous electrical activity that is generated within the brain. The key here is that you can have a variety of clinical symptoms, so not everyone's seizures are going to be the same. And it's only if you have a recurrent predisposition to this that you ultimately end up being termed as having epilepsy. Now, when I see someone who has suspected epilepsy, we always start first with a clinical event. So I rely on the patient or their family to tell me what exactly is going on with their event. Now, when I hear that event, there could be a lot of different things that it could be. And this is a very busy slide, but I want to kind of shift, split the page in half and look at the left side of the page and then the right side of the page. The first thing to kind of talk about are there physiologic or non-physiologic episodes that look like seizures but aren't actually due to electrical activity. And those can be very varied in terms of what those could be. The common ones that we sometimes see are cardiac issues, whether it's heart rate irregularities, a tendency to have syncopal episodes or fainting spells. Sometimes we have medications that induce events, migraines, stroke-like episodes, sleep disorders, movement disorders, infections, changes in your blood chemistries, whether that's sugars, sodium, other chemistry values. All of those things could provoke episodes that look very much like a seizure. We could also have things due to stress or panic attacks or trauma that can sometimes lead to having seizure-like events. On the other hand, we very clearly see a lot of seizures that are due to abnormal electrical activity, so-called epilepsy. But even within that, all epilepsies are different. There are epilepsies that are due to one part of the brain being activated, a so-called focal epilepsy. And within that subgroup, there are patients that lose awareness during their seizures and those who do not, and some that have a spread to a convulsion or bilateral tonic-clonic activity in the medical terminology. And in those cases, we're focused on, is there a structural abnormality within the brain that's generating this process? On the other hand, there are people that have seizures that are due to bilateral activation of the brain, very large networks that are generating their seizure. And in those cases, it's not usually due to a structural abnormality, but more in line with an epilepsy syndrome, and we think about maybe genetic causes perhaps. Having looked at all this busy slide, the most important thing that I want to discuss here is just the fact that the treatment's going to vary across the board. So if we think this is due to abnormal electrical activity, there's a role for medications perhaps more aggressive interventions, which we'll discuss later. On the other hand, if it's due to heart-related issues or if it's due to medications, then the treatment's going to be very different. Withdrawal of those medications, addressing the heart issue, or whatever the underlying etiology is. I'm going to shift gears here and talk a little bit about what happens if we do think it's going to be epilepsy. And this is a busy chart, but I think it's a very helpful chart from the medical literature. In this study, they looked at over 1,000 patients who had newly diagnosed epilepsy. And so they felt very strongly that the seizures were due to abnormal electrical activity. And I highlighted a couple things in red here. On the far left-hand side, the column is going through the number of medication trials they've gone through. And then the other column that's highlighted in red is the percentage of people who end up becoming seizure-free. So with that very first medication trial, about 50% of people will have a favorable response. And by favorable, meaning seizure freedom. However, if we go to the next medication trial, let's say you're in that 50% who don't respond, you try a second medication, either added on top or switched over to that medication, only about 13% of that 50% of that group will respond. As we go further down and we try our third medication trial or our fourth medication trial, we get lower and lower in terms of our likelihood of getting a favorable medication response. And if you go down to 5, 6, 7, 8, 9, there's almost zero in this population of patients. That doesn't mean that the medications are guaranteed not to work, but there becomes a less and less likelihood of having a favorable outcome with those medications. For that reason, a practical definition of so-called drug-resistant epilepsy came up. And while it seems obvious a patient doesn't respond to medications, therefore they're drug-resistant epilepsy, in the practical clinical sense of this, we really use the failure of two medications that are not failed because of side effects, but because they're not effective for controlling their seizures. So anyone who does not respond to 2 or more medications, we start thinking of them as having drug-resistant epilepsy. So what happens if you fall into this category? Does that mean we have no other options? And the answer is no. There's very many alternative therapies that we can discuss. And I'm going to list them out, not in any particular order, but rather the extent of options that are out there. We do have the option of potentially offering epilepsy surgery for some patients, and that is removal of a certain part of the brain that's generating the seizure. There's also the possibility of placing stimulation devices. There are different types of stimulation devices that Dr. Cannon, I'm sure, will discuss, including stimulation devices placed in the chest, called a vagus nerve stimulator, or in the brain itself, responsive neurostimulation, or neuropace. There are also dietary therapies that are used, and these are commonly have been tried in the pediatric population, the ketogenic diet, but more recently the modified Atkins diet has also gained increasing acceptance and utilization as a mechanism to help control the seizures. You heard Dr. Maheshwari talk about medical marijuana, and there's also clinical trials, whether that's clinical trials for new medications, novel medications, or actually for new devices. There are things like deep brain stimulation that's actually occurring, ultrasound as a mechanism to try to help control seizures. So those options all are possibilities. When we have patients who are going to be evaluated for their drug-resistant epilepsy, we have several core tests that we ultimately recommend to try to better characterize the seizures themselves and then better define what our actual treatment's going to be. And there are 3 main tests that I'm going to talk about. These all fall under the broad category of phase 1 evaluations. And so the first one that I want to talk about is the epilepsy monitoring unit. This is a hospital admission where we're doing video EEG monitoring. And there's really 2 parts to this test. There's the electrical activity part, or the EEG part, where electrodes are going to be placed on an individual's head, and that's going to be continually monitoring their brainwave activity. And this is going to show us when and in what circumstances where the seizures are coming from. The timing, the distribution of that seizure, the location of that seizure. In conjunction to this, we also need the video part of this. It's very important to understand what's clinically happening during a seizure, and the video is going to be constantly trained on a person to try to monitor their clinical behaviors. Really, you need both of them to truly understand what's going on during a seizure. Now, over the last few years, there's been increasing availability of home EEG monitoring systems where you're able to do similar kind of techniques at home. And in certain cases, that's a beneficial test and a worthwhile test. However, there are clear benefits to doing this in the hospital. And probably the most important reason why it's important to do this in the hospital is we have the ability in the hospital to safely provoke seizures. I would not recommend trying to provoke a seizure at home and the risk of having a seizure, the risk for injury, the cause for harm. And those are dangerous things. There can be very serious things that go on during a seizure, and it needs to happen in the setting of medical professionals who are comfortable dealing with the seizures, whether that's physicians, nursing staff, technologists, and the rest of the hospital team. And so we have several ways that we typically provoke seizures, and this is individually tailored based on the patient's seizure triggers. One of the more common ones that we use is weaning medications. We can also sleep-deprived patients. We can administer flashing lights, deep breathing, alcohol in certain cases, not in the pediatric population, I hope, but in the adults at least. And we can do several other things. Sometimes people have events provoked by changes in their body position, so sitting to standing, exercise. All of these things can be performed in the hospital as a way to provoke the seizures. The other reason why I like the inpatient hospital testing is that you can tailor the testing based on the person's individual seizure type. So let's say we hypothesize that our patient's seizures are due to their abnormal electrical activity in the brain, but we do the testing and we find out, wait a minute, it's not actually that, but rather due to something else. Maybe it's their heart, maybe it's because of their chemistries. Well, wouldn't it be nice to be able to test those things at the same time? Couldn't we also check their cardiac function? We'd also check, is there a reason why they're having underlying metabolic abnormalities? And we can do these kind of things in the hospital. I'll go into the benefit of certain imaging tests as a part of a surgical evaluation for epilepsy. Let's say you fall into those categories, we're able to do some of those testing in the hospitals. We're able to facilitate a lot of testing at one given time. And then we also have the ability to consult experts in the field that maybe are outside the true epileptic seizure realm. And so if there are issues related to cardiac issues or kidney function, we can consult them and have inpatient consultations for those very reasons. A recent paper came out talking about what are the benefits of the epilepsy monitoring unit and why should we order this in certain individuals. And this is a complete list of those reasons. I'm going to go over a few of those. The first one, I think is probably the most important one, is if you're not really sure what you're treating and you think it's epilepsy but you're not responding to medications, we really should confirm the diagnosis. And really the epilepsy monitoring unit is the best place for us to do that. If we know that you have seizures and you're not responding to medications and we're wondering about possibly considering surgery, doing a pre-surgical evaluation is necessary, and it's important to do that in the hospital. If we're trying to adjust your medications and worried about the possibility of having worsening seizures as we transition out one medicine and onto another medicine, the hospitalization allows us a way to make sure that's not actually going on. And it allows us to intervene if in fact we run into problems with the transition of medications. And a lot of times the realm between seizures and side effects can be very difficult. They can sometimes be the same in certain individuals, and it's very hard to know what to do in the outpatient setting. Do we add on more medications because we think it's seizures, or do we actually back off the medicines because we think they're causing too many side effects? If you're not really sure, doing this in the hospital allows you a way to confirm whether or not they actually are abnormal electrical activity seizures or due to something else altogether. The second test that's a core part of this phase 1 evaluation is the MRI scan, or magnetic resonance imaging. And this scan is looking for any sort of structural change within the brain that may be the result or may result in seizures. If we are in a scenario where we're looking for pursuing surgical options for epilepsy, finding an abnormality in the brain increases the likelihood of us being able to operate in that area, remove it, and actually have a positive seizure-free outcome going forward.
Do you happen to know when the 70 is going to be available to patients, and do you know if it will be available to the pediatric patients?
Great question. So as of right now, I think I'm going to reiterate what Dr. Maheshwari said. You guys are reading my mind and all the points that I want to bring up. So I'll answer that in just a sec. So I'm going to go with the fact, I want to mention first that the way that MRIs are done right now, it's very variable across the board. And so when you think you're getting an MRI brain at one institution, it may be very different from somewhere else. And so when you have an MRI and you're looking for underlying causes of seizures, it's very important that you make sure it's done as an epilepsy protocol MRI. And there are certain sequences that are done as part of this to make sure that we're looking for common causes of seizures, but also rare causes of seizures. There's also the issue of magnet strength. And so there are higher degrees of magnet strength that are more likely to pick up abnormalities. And so commonly right now, a 3 Tesla magnet is the highest magnet that we use clinically. 7 Teslas are available. As of right now, they are only in the research venue, although in some institutions around the country, they're starting to use 7 Tesla magnets clinically. It's becoming a little bit of an issue of, if you have a really strong magnet, you might be able to pick up an abnormality, but you're very prone to artifact. And so if you have a lot of movement, that can really mess up the study. Or even if you're not moving, you can have a little bit of excessive artifact that confounds your study. And so we're still trying to figure out what's the right balance. Is 7T really the right test for everyone? Or do they really need a 3 Tesla magnet first, make sure it's negative, and then if we're really concerned about a specific abnormality, then pursue the 7T? So we're still working on all of those issues, but I imagine over the next few years you'll see more and more 7 Tesla magnets available, certainly for research use, probably even for clinical use. And probably the most important thing is you may have the best MRI scanner in the country, and it is the perfect epilepsy protocol, and it's really good quality, but if you don't have someone who's comfortable interpreting the study, then you may end up getting a normal study when in fact it is abnormal and there's a clear cause for why people are having seizures. And so I want to show you an MRI scan, not because I expect you to understand what's going on here or really to talk about specific details of this MRI scan, but this is a patient who came to me who had an outside quality scan. It was a very good quality MRI. It was high magnet strength, 3 Tesla. It was done as an epilepsy protocol scan. It was read as normal. The patient was still having seizures and wanted a second opinion, so they came to our office. And so I'm going to show you a couple screenshots here. When we were going through this MRI scan, this area is focusing on the part of the brain called the temporal lobes, which is in the adult population a common area where seizures occur. What we start to see by the area up here, which is our hippocampus, is I'm going to have a soon, is a little bit of a bright spot that's there that clearly shouldn't be there, and that was picked up when we actually reviewed this scan with our radiologist. And so we found this nodular heterotopia that is close to the ventricle and close to the hippocampus that could, in theory, cause someone's seizures. What was interesting about this patient was that was not all that we found in this scan. The radiologist did not see anything more, but when we looked at this patient some more, we noticed that there's almost this string-like appearance from that nodule there carrying down to the bottom of the brain. I'm going to highlight this area right here. And in fact, this little sulcus and gyrus here of the brain is a little bit thicker than all the tissue around it. That actually is abnormal as well, and that was missed on the initial review of this scan. This patient ultimately ended up going through a surgical evaluation, and we got confirmed this with surgical monitoring. And it turned out that area that was missed was actually the part of the brain that was actually generating the seizures. The point I want to make here is, one, multiple people need to review MRI scans, particularly when we're not sure if they're normal. They got to be comfortable in reviewing their scans. And two, when someone has an abnormality, there's a high likelihood there might be another abnormality that goes along with it. It's a very common, we're discovering this more and more, that these then tend to come in clusters. And so it's possible that there's additional findings there that we're not picking up on.
What was that?
So that was a nodular heterotopia, and that was cortical dysplasia is the other part of this. And cortical dysplasia is actually a very common cause of seizures that frequently are missed on MRI scans if they're not done correctly or if you don't have someone who's comfortable interpreting those. And so the last test that is part of this core-based package in terms of the phase 1 evaluation is neuropsychologic testing. And Dr. Maheshwari mentioned this a little bit earlier. And so this is a test that we really use to check and understand how patients' memory is doing and how their cognitive function is overall. And we know that seizures can cause a lot of issues with your functioning. And we don't know sometimes if it's the seizures itself. Is it the underlying structural problem within the brain that's causing the seizures? Is it the medications? Or is it something else altogether? And this test can give us an idea of which realm do you fall in if you're having issues. As it pertains to surgery, it helps us understand what part of the brain is causing seizures. We know that certain functions of the brain are restricted to certain parts of the brain. And if we find a functional deficit, we can pinpoint an area that we might think is causing the seizures. The other part of this that's beneficial is as we start talking about maybe removing part of your brain, we get worried about, are we going to be left with side effects or potential effects of this? And we obviously don't want to have that possibility happen, but this test will help us identify if we were to take out a certain part of your brain, would your functions be affected by that? And that's an important part of this discussion, which I'll hone on a little bit later on. And so I want to switch gears now and talk about a little bit more about the special testing. I'm going to start first with talking about the epilepsy surgery testing, and then we'll talk about some of those other special circumstances. Things don't always work out like we want. We always hope that the MRI study that we order and the epilepsy monitoring and evaluation study that we order and the neuropsychologic testing will all point us to one clear focus in terms of where your seizures are coming from, why you're having seizures. But a lot of times the data can be conflicting. It may be completely normal, it may not show us what we want, or it may not really tell us exactly what we're looking for in terms of that precise localization of seizures. When that happens, we really need additional testing to help better understand where this is coming from and the potential risks as we move forward. There are several tests that we order as part of this package. One of them is called the PET scan. It is a measure of breakdown of sugar in the brain. And so in contrast to the MRI, which is looking for scarring or structural abnormalities, this is looking for how well is a part of the brain breaking down sugar. Most of the time, abnormalities that cause seizures will have a decreased breakdown of sugar. And so we're looking for deficits of breakdown. Although if you have a tumor as a cause of your seizure, it may show increased metabolic activity in that region. It's been shown that if you have a patient that has no abnormality in their MRI, but their PET scan shows a very clear abnormality, if you remove that entire region, you're much more likely to have a seizure-free outcome. So it's very strongly correlated to their likelihood of having seizure freedom if that's the case. I'll show you an example of this, but it is clear on a lot of these tests, including the PET scan, that visual analysis of the study alone is probably not sufficient. It is very easy when you see shades of red, orange, yellow, and green to miss the area that's abnormal. However, if you are able to register it with the patient's own MRI and perform advanced modeling techniques, you're maybe able to identify the areas of abnormality and maybe even in retrospect find an area that was actually abnormal on an MRI. So let me give you an example of this. This is an example, it's a quick snapshot of a patient who had a PET scan. I'm showing you 2 cuts from that MRI, or the PET scan. Looking at this really quickly, you may look at it and say, oh, it looks pretty normal, not having known anything about the PET scan. What we're looking at here are just shades of different red, orange, yellow, green, and blue, and we're looking for areas of asymmetry. However, to the trained radiologist eye, they may be able to pick up this area, which I circled in yellow, that actually looks asymmetric when you look to the other side on the left-hand side of the screen. This actually was an area that has decreased metabolic activity. I would not expect most people to pick this up if they were quickly scrolling through a 50-sequence scan. It's very hard to pick that up. Now what happens if you actually have the ability to compare both the MRI scan, the PET scan, and fuse the 2 together, which is done on the far right-hand column? You're much more likely to be able to pick up these abnormalities, and you might be able to, when you go back to the MRI shown on the far left, say, wait a minute, that area doesn't look quite so normal, whereas before it was read as normal. And so this is a case where not only did they find this area of abnormality, which is a little bit lighter here, they found that on the fusion study right here. They actually went back to this MRI and said, wait a minute, this tissue right here looked a little bit thicker than everything else around it. And this is actually a patient who had, again, cortical dysplasia, and the PET scan helped find that out. Another test that we use is a Spect Scan. And in contrast to the PET scan, which is looking at breakdown of sugar, this is looking at blood flow in the brain at any given time. And we really are interested in looking at 2 different types of blood flow scans. We're looking at what happens during the seizure, and then we're looking and trying to compare that to what happens outside of a seizure. At the time of the seizure, as you can imagine, there's going to be increased blood flow going on in the brain, particularly where the seizure is originating. And then outside of a seizure, it may be completely normal, or it may be slightly decreased, depending on what's causing the seizures. To do this test, you really need to have ongoing EEG monitoring. You need to be able to quickly identify where the seizure is starting, and when you identify that seizure pattern on the brainwave activity, then deliver the radionucleotide injection. And then you're able to hopefully get a positive result with that. Just like PET scan, if you look at the study by itself, you may miss the subtleties, and you really need processing that might be able to pick this up. And again, I'll show you an example. This is an example of a Spect scan that was done. Column A is what's called the interictal scan. So this was done outside of the setting of a seizure. And column B is what happens during a seizure, or the ictal scan. It may not be particularly obvious on here, but you might notice that on column B, there's a lot more red on the left bottom side of the screen than you see on the left column, on column A. Does everyone see that? Okay. This is an area of focus or increased blood flow during a seizure, and actually points to a seizure probably coming from that area. And in fact, it's confirmed later on in this patient. What happens if it wasn't so obvious? There are cases where you look at them, and these red, orange, and yellow just blend together, and you can't really tell the difference. This is a more dramatic example. But if you don't have that possibility, you actually can do advanced processing where the computer is able to subtract out the 2 results. And then not only are they able to subtract out the results, they're able to fuse that on the patient's own MRI. And so you have what's called a Cyst study. And here it very nicely shows that the area of red and orange is clearly centered around this temporal lobe right here. So this is going to be a very valuable tool if you don't have a very clear result or an obvious result between the 2 studies. Another test that we use is something called magnetoencephalography, or MEG. We're actually very fortunate in Houston. We have 2 of these in the city. I think this might be the only city in the country where there are more than 1 scanner, so we're very fortunate to have 2. And what this study does is measure the magnetic field generated by the brain. Most of all the activity that we focus on when we talk about epilepsy is electrical activity. The EEG's basis is measuring the electrical activity. However, there's some problems with that. As the electrical activity is generated from the brain, it has to travel through the brain, it has to travel through the skull, through the skin, through the scalp, through the muscle, through the hair, and then ultimately we get onto the electrodes that we have on a patient's scalp. As it does that, all that activity dissipates. And so what you see in the brain is orders of magnitude more than what's going on in the skull. And so we can sometimes be tricked by what's going on. In contrast, magnetic field doesn't have that limitation. Magnetic field will travel right through the skull, not be dissipated in any sort of way. So it can actually be more helpful in terms of pinpointing the exact part where seizures occur. The downside to this study is that magnetic fields that are generated by the brain are very, very, very small, and they're much smaller than the normal electromagnetic fields that are generated by the earth or ambient environmental noise. And so you need a really sensitive device that will amplify the signals, but also tune out all that environmental noise. That makes that study very, very expensive in terms of the ability to have a machine, and so that's why there's so few in the country. There's probably about 62, I think, at last count, in the country. We're just fortunate to have two, right down the street. So this is an example of a magnetic field study. The top two rows that are of activity that are shown here and here are actually the magnetic field activity. And the areas that I highlighted in red are actually the abnormal activity. We always record this activity simultaneous to electrical activity. And the thing that I want to show you here is you can see here that almost all the sensors in this particular magnetic field study are abnormal. It has what's called a sharp wave. If you look down to the electrical activity, only a couple of them actually show that abnormality. And that again goes to show you how sensitive the magnetic field study is in contrast to the electrical field activity. What's really neat about this tool is you're able to then take this activity, get several of them modeled out, and then model that activity onto a patient's MRI. And in certain cases, like this case for example, all that activity may cluster in a particular part of the brain and actually may pinpoint where the seizures are coming from. This is a patient of mine who had this very study after having everything else show up negative. This study ended up showing a very small part of the brain that was active right here. And when we ended up doing the actual monitoring for surgery, lo and behold, the seizures came right from that very spot. And that was the only spot that needed to be taken out for him to be seizure-free. So it can be a particularly valuable tool in certain circumstances.
Would it matter if you're not having a seizure? Would it still show?
Correct. And so all the stuff that I show here is abnormal electrical activity outside of a seizure.
Okay.
There are cases where we actually capture a seizure in the scanner, which can be very valuable. That's much more likely on the pediatric side. This is one of my areas of interest. I do this for the adult side. I've never had a patient actually have a seizure in the scanner. But very frequently, probably over 90% of the time, we'll get some sort of information that points to where their seizures are coming from. Okay. All the tests that I've talked about really focus on understanding where we think the seizures are coming from. Can we better identify where the seizures are generated from? What part of the brain, what region? Are we looking at structure or blood flow or magnetic fields? But that's only part of the question. When we start talking about epilepsy surgery, we need to talk about two things. One, can we pinpoint where the seizures are coming from? But probably more importantly, as it pertains to the individual themselves, if we were to do something on this, are we going to cause any problems? Are we going to leave you with deficits that leave you worse off than not operating on you? And the functional MRI is one way we can help answer that question. We know that there are certain parts of the brain that are important for very important functions like language, like ability to move, ability to see, and ability to sense or feel things. And this study shows activations of blood flow at the time of doing this task. This is an MRI scan that's a little bit fancy in that you're actually doing a task in the middle of a scan. And so in patients that are shown on the bottom left here, what we're actually doing is having them move their tongue repetitively in this instance. We're having them tap their hands repetitively, or we're having them tap their feet. And in each case, we see a slightly different area of activation that corresponds to the region of the brain that's causing that function. We obviously want to make sure this is not where your seizures are coming from if we were talking about removing that part of the brain. And the same thing applies to language, which is shown on the right here. This is a patient who was talking and interpreting a series of words in front of them on a screen, and we see two areas that are active on the scan on the left side of the brain or the right side of the screen. This is where the language areas of the brain are generated from. Now, what about memory? In the adult population, most of the seizures come from the temporal lobe. A lot of the patients we end up evaluating and potentially operating on are coming from the temporal lobe. And the temporal lobe is very clearly important in language, but also in memory. I just showed you that the functional MRI might be able to help us with the language. I gave you an example of that in the prior screen. But unfortunately, the functional MRI does not help us in understanding which part of the brain is important for memory. And so that's a big question and a big concern when we start talking to patients is, are we going to leave you with a memory hit after going through a surgery? And that's a big concern. We obviously do not want to touch that at all. And we do have an answer for it, although it's a fairly crude test. It's called the WADA test, and that's a way that we can better identify where memory is coming from within the brain. What this test consists of is an injection of a numbing medication that's done via an angiogram into one of the major arteries of the head and neck. It causes a temporary disruption of activation of that given region. And so you can have difficulty speaking, difficulty moving one side of your body, you might have vision problems, you may have memory problems. We're going to be performing testing during this actual numbing medication injection to understand, are you able to speak? Are you able to remember things? Are you able to move? To really understand what part of your brain is truly responsible for these given functions. Okay. I want to talk a little bit about autoimmune epilepsy, kind of a completely different area. It is an area that you may have heard about that's gotten a lot of interest over the last few years. And it's very clear that there are cases where people have seizures that are not due to just abnormal electrical activity, but due to some sort of inflammatory process. Whether that's inflammatory process within the brain or inflammatory process within the whole body, either are possibilities. What we've struggled with is trying to understand who those patients are. How do we know those are the patients that have that inflammation generating their seizures? The reason why this is so important is that in these particular subset of patients, they tend not to respond to our traditional seizure medications. They also tend not to respond to our surgical therapies. There are patients I know who have gone through surgeries, they've removed part of their brain, and unfortunately they still have seizures because the underlying autoimmune process wasn't fully treated. We are struggling with this in our current practice. Which patients are the ones that we should work up for this autoimmune cause before we start talking about surgery or medication trials, and which ones really need this autoimmune approach to treat them? I put this screen on the far right here as a guideline that are out there. It's as good as any that's out there as far as I know. It can be very challenging to pick out the patients that have this as a possible cause. Some of the things I want to highlight here are patients that have had seizures that rapidly progress, and usually something that rapidly comes on within a course of a 3-month time period or less. If they have multiple seizure types, and that seizure type seems to be evolving over time, that can sometimes be a red flag that maybe it's something different than our traditional seizures. If they have any sort of history, whether it's their own history or a family history of autoimmune illnesses, whether that's rheumatoid arthritis or something along that spectrum, that may be a sign that maybe this is related to an autoimmune cause. Do they have any sort of history of a cancer, whether it's recent or in the remote past? Sometimes cancers can be related to development of autoimmune seizures. Do they have a preceding viral illness that was the cause, so it seems, of all their seizures? That can be a big red flag that maybe this is related to autoimmune causes rather than something completely different. And then the last two are actually evidence of the inflammation itself or evidence of the antibody, which at that point makes it a little bit more clear. There's a lot of controversy in this subset of field. We, to be completely honest, don't know what the right approach is in terms of testing and imaging and laboratory studies. One of the things that we commonly discuss is how do we best test for this? If we do think someone is suspected to have autoimmune seizures, do we need to sample their blood to test for it? Do we need to sample their spinal fluid to test for it? Some antibodies are only present in the spinal fluid but not present in the blood. And the opposite is also true. It's only present in the spinal fluid but not in the blood, or in the blood but not in the spinal fluid. We don't really know what the right answer is. Sometimes we do a shotgun approach and do both. But is that really cost effective? Is that the right approach for everyone? I hate to talk about it, but insurances can sometimes be very challenging to navigate this. I mean, these tests can be very expensive, and insurance companies may not want to cover them. And so, is it really worth fighting for these tests when we're not sure it's truly what's going on? And it can be very difficult, and it's really a customized individual decision. There are panels out there that you can send multiple antibodies and screen for several different antibodies that are the most likely autoimmune causes, versus sending off for just specific antibodies. That is generally cheaper and easier to perform, but maybe you don't know, maybe there's no clue as to what specific antibody is causing all of this. In terms of imaging studies, sometimes we use imaging studies to help support this diagnosis. Sometimes there are MRI findings or PET scan findings that help support an autoimmune cause versus traditional epilepsies. There are also things like systemic scans that sometimes systemic processes, whether it's rheumatoid arthritis or lupus, may be causing you to have seizures that are autoimmune generated. And looking in the rest of the body may give us some idea of those possibilities. And then finally, there are antibodies that clearly cause other problems than just seizures. They may cause diabetes. They may cause thyroid problems. They may cause pelvic issues. And if that were the case, we need to screen for those possibilities as well. This is very important as it pertains to the clinical history. I think it's very important when we have these challenging cases to not just focus on the seizures, but focus on all the other issues. If there are other systemic issues going on, weight loss, endocrine issues, pelvic issues, those are things that actually are relevant to our clinical discussion. And so I frequently will ask about all these other body systems where, even though it doesn't seem like it clearly will pertain to the epilepsy that we're trying to treat. I threw this slide in here because if we do suspect someone is having epilepsy, there are several treatments that we try to undergo. Most of it's centered on IV steroids. Sometimes we can do oral steroids. There may be IV immunoglobulins that we end up treating with. Some people have something that's called plasma exchange. The problem is not everyone responds to this, and so it's hard sometimes to know how far do we push it. If we really think someone has autoimmune seizures and we have the antibodies to prove it, by all means we're going to go very aggressive along this approach. But what if we think someone has autoimmune seizures but we never found any evidence of it? Do we start with one individual treatment and stop there? Or do we go to the next one, or the next one, or do we go to the 7th line agent? And we don't know, and that's part of the challenge. I have several patients in my clinic where we really discuss this and whether or not we need to continue along this autoimmune treatment route or some route altogether differently. Another thing that comes up a lot, although probably more in the pediatric population than the adult population, although I think that will change, is the role of genetic testing. There are a lot of genetic causes of seizures, and that number has grown over time, and it will continue to grow. Right now, probably about 400, that number is probably outdated. At least 400 genes are now linked to epilepsy. There's probably much, much more than that. If you look at just families of patients that have seizures, you can see that over time, most of these patients that have seizures have a higher risk of developing seizures within their close family members than the normal population. So even in seizures where I would never have guessed that they had a genetic culprit, there's a higher risk of having someone in your family having those seizures. And to me, this suggests that a lot of our epilepsies have some genetic component. It may not be the sole reason they're having their seizures, but there is some association with their genetic makeup. In terms of when we should perform the testing, this also can be very difficult. What I would recommend as far as a general guideline would be patients where we struggle to find a cause of their seizures, particularly if their MRI is completely normal. If they have a strong family history of seizures, that should be a red flag that maybe there's some sort of genetic component to their seizures. If they have some sort of developmental abnormalities, whether that's on their brain scan, or if they actually have developmental disabilities, such as autism, intellectual disabilities, learning disabilities, or other developmental abnormalities. Patients that have sudden unexplained death in young relatives who are less than 40, whether that's passing out, heart issues, or even actually seizures where they suddenly died, those are patients where there may be a genetic culprit that's potentially causing their seizures. And then not so much on the epilepsy side, but on the treatment standpoint, there are patients who will have are very more likely to have adverse reactions to medications, particularly of Asian descent, if they have a certain genetic abnormality or finding. And so it's important to screen for that possibility as well. Going back to this, I think there will be more and more instances where we should be genetic screening in the future. There is a concept called precision medicine, which some of you might be familiar with, which is the idea that we tailor our testing and ultimately our treatment based on the testing that we perform. I think genetic testing is one of the tests that may help us get there, and I think we're not there yet, but I think in our lifetimes we will see genetic testing that will help design what kind of tests we order, or maybe a better sense of what medicines may be the better treatments for them, or maybe identify patients who aren't going to respond to medications and may be better suited for something additional. So what about the next steps? We went through all these series of tests and you had a whole bunch of tests. What happens next? And I think it really depends on which kind of pathway you are on. If you're undergoing a surgical evaluation, there are several next steps. If you have a series of tests and we are strongly considering surgery of any type, whether it's a surgery or a stimulation device, the next thing that we end up having done after completion of the test is something called a patient management conference. And we have a multidisciplinary group of individuals, neurosurgeons, epilepsy doctors, neuropsychologists, imaging doctors, radiologists, all of whom were present at the conference and discuss our individual patients, all the test results, and we really kind of talk about, is there a risk going forward with surgery? What are our recommendations as far as what the next steps are? Do we need additional tests? If all of that is if everyone is in favor of moving forward with surgery and the patient and their family are interested in moving forward with surgery, then we actually meet with the surgeon and talk about the actual process, the risks, the benefits, and make sure everyone's on board with that. And in certain cases, we may need to do what's called a phase 2 evaluation, which I'll talk a little bit about in the next step. If we're talking about other cases that are not surgically pertained, it's very important to meet with your epilepsy doctor, whether it's a neurologist or a formal epileptologist, to assess the test results. I'm a big fan of having a quick follow-up after a lot of tests to make sure that we understand the test results, the implications of this test, and also discuss the next steps, whether it's treatment or actually more tests if necessary. So one of the big last steps that a lot of our patients may end up going through if they're going through surgery is something called a phase 2 evaluation. And so I've just shown you, 10 slides of all these different tests that we order. You may be asking, why is more testing needed? Come on now, what's the deal here? Let's get this done if that's what we need. And a lot of times, surgery may be considered a good option, but we're just not really sure. Maybe we need a little bit more exact information to pick out exactly where the seizures are coming from. Or maybe we need to make sure that the seizures are not in an area that's important for language or memory or ability to move. And so when we do that, then we want to say, let's actually get direct brain recordings to confirm that possibility and ensure that's not the case before we actually do something like brain surgery. And there are two main forms of this, which I imagine Dr. Kanon's probably going to talk about in his talk a little bit, so I'll briefly introduce these concepts. One is Stereotactic Eeg or Stereo Eeg, and the other one is the Subdural Grids and strips. With the subdural evaluation, what we're trying to do is pinpoint the exact part of the brain where the seizures are coming from. And we do this by opening up a hole in the skull and placing recording electrodes like shown here. It's the 4x4 grid that's placed. In contrast, a stereotactic EEG takes a different approach. It places small little tiny holes in the skull, and you place small little electrodes through that to sample from different parts of the brain. Now there are pros and cons to both of these approaches. Anyone who tells you that one option is the way to go is wrong. Not everyone, it's a very individualized decision here. And there are some benefits and cons for each of these studies. As it pertains to the stereotactic electrodes, the way this is done is by using targeting software. So if you have a specific part of the brain, particularly if it's deep in the brain that you want to sample from, this is probably the best way to do that. It is also it's more minimally invasive, so you don't need an actual open craniotomy to remove your part of your skull to do this. That is nice if you've already had an operation, or if you're really concerned about the ability for you to tolerate a large open craniotomy, whether for medical reasons or pain issues or something else altogether. Let's say you're not really sure and you're actually thinking it may be coming from 2 parts of the brain or multiple parts of the brain. You're not really sure where this is coming from. This allows you to sample from multiple locations in the brain in a way that's not too hazardous to a patient's health. On the other hand, the subdural grids are also beneficial in certain cases. If you're really worried about the ability to identify where exactly memory is coming from, or language, or motor skills, having a broad strip that's placed over directly on the brain surface is much more likely to help you pinpoint those out in precise detail. And so when you're talking about trying to map what's the most important cortex for certain types of functions, it's much better to do the subdural approach. So in summary, going to a level 4 epilepsy center allows you to have a multidisciplinary, comprehensive approach to evaluating seizures. And to me, by and large, the mainstay of what we do is through the epilepsy monitoring unit. It's really important, not only for patients that have refractory epilepsy, but also for people where we're not really sure what we're treating, or we're not having a positive response to their seizures. And this really allows us to really characterize what's causing the seizures and potential treatments going forward. The treatment options are varied and really depend on the specific type of seizures we're dealing with, as well as patient preference. A lot of this is a collaborative effort between the patient, the family, and the doctor. We weigh the risks and benefits of each of our approaches. And we certainly vary our testing based on whether we're trying to pursue a surgical approach or whether there are red flags that suggest maybe there's a genetic cause of some of our seizures or an autoimmune cause for some of our seizures. The last slide I want to leave you with is just listing out the level 4 epilepsy centers in Houston. And what I really want to focus on is the right-hand side of the screen here. One of our national groups has put out guidelines as far as how to manage patients with seizures and challenges in treating them, has listed out this kind of algorithm. And I think it's a very effective flow chart in terms of how we should approach this. And everyone, not just in the epilepsy community, but just in the common medical community, should approach seizures. Very frequently, when someone presents with a first-time seizure, they may go to the emergency room. That may be their first site of being diagnosed with seizures. Or it may be their primary care doctor. They may not necessarily see a neurologist, or maybe they see a general neurologist, and they may provide them initial care. And that's fine. There's no issue with that. However, if the seizures aren't controlled after 3 months, despite medication therapy or some other approach, then they really need to go to a neurologist or a specialized epilepsy center if one's close by. If there's any question about the diagnosis, if we start wondering if maybe it's not due to abnormal electrical activity, or maybe after a year the seizures still aren't controlled, by that point they really should be going to a specialized epilepsy center. And I cannot stress that enough. Going to a specialized epilepsy center allows you access to a lot of different tests. It doesn't have to always be for surgery. And so I spend a lot of time talking about surgery, but a lot of my patients don't want surgery. They want other evaluations, whether it's for autoimmune causes or genetic causes or something else altogether. And only by going to a specialized epilepsy center do you get that comprehensive approach at evaluating all this. All right, I think I'll stop there and I'll open it up for any questions. Yes?
I have a question. I'm talking in retrospect, but the subdural grids and strips, so on patients that are nonverbal or delayed globally, do the surgeons have a way to map out since the patient's not talking during the surgery or doing the tongue or tapping the finger, are they pretty certain that they're not taking out areas that affect that? And if they did, is there other parts of the brain that can take over those responsibilities?
Wonderful question. And so it's certainly a greater consideration in patients who are younger, where we have to worry about this issue. When you are younger, the brain does have a remarkable ability to regenerate functions in other parts of the brain. But aside from that possibility, there are other ways for us to be able to measure, at least crudely measure function, even if a patient's not able to communicate with us or talk to us. And this mainly is more for motor function. We do have the ability to use electrical stimulation during a possible procedure where we're actually able to reproduce motor functions without patient cooperation. So even if they're not responsive, we can deliver some stimulation to try to see if that area is responsible for a movement. However, that's not going to be responsible for language or sensation, and so there are risks with doing some of this. We hope that by then we have some sort of ancillary testing. Maybe our functional MRI has pointed to us an area where maybe language is coming from, or where sensation is coming from, and so we are hoping to avoid those altogether. But yes, that is a big challenge and one of the big discussions when we start talking about, do we want to undergo something like this? Will we get the test results we need?
And the statistics on 45% of patients respond to the first drug that's chosen, and then it goes down to 0.2% when you get down to the fifth drug. So my question is, why keep throwing drugs at a patient that is not responsive to a host of them? There's new drugs coming out all the time that are FDA approved, right?
Sure.
And so, I mean, is there an answer for that, or are we just at odds, trying to beat the odds here?
I think it's a combination of both. I mean, I think one, it's sometimes very hard for us to try to pursue something that's more aggressive than medications when we're talking about brain surgery. There's a big impact to a person going through brain surgery, and maybe we're all a little hesitant to push someone towards that when we could just try another medication perhaps instead. And so there's a tendency to maybe want to try those or maximize that as much as possible. The other part of this is a lot of the older medications tend to work in similar ways. And so as we start getting newer medicines that maybe work in a novel, different way, maybe there's something to that new medicine that might offer some additional benefit. And the things that come to mind are medicines like Fycompa, for example, which is the first of its kind in terms of how it's functioning. Or medical marijuana for that matter, which is the first of its kind to work in the way that it's working. Maybe that is the medicine that might offer some additional benefit. So I think we're walking a fine line. We always have to weigh those odds. I would say I'm brutally honest in clinic. I show them the numbers. I tell them that doesn't mean we necessarily have to give up on medicines, and I'm happy to try them. We should be realistic about the likelihood that those are going to offer any significant improvement.
Have you ever heard of mesenchymal stem cells being used?
Not on a clinical level, and not on a clinical level for epilepsy, particularly in the adult side. I don't know if there's anything on the pediatric side, not that I'm aware of.
Okay, we have a question online. Somebody's saying that they had a 5-day video EEG, which confirmed their diagnosis and that the seizures would be lifelong. They've had 3 years of no seizures on medication. but that had an increase in memory loss, word usage, and stroke-like episodes. What would be the best test to start with to look at for those additional problems?
That can be very challenging, and so I think a lot of it falls down to whether it is the side effects of the medications that are causing these issues. Do we think it's actually the underlying cause of the seizures that's causing these issues? Or is it perhaps seizures that are not detected clinically? Sometimes we can see electrical seizures that don't generate any clinical symptoms, and it's not through additional testing that we actually tease that out. So there could be a lot of different things that we pursue. I'd probably suggest maybe an MRI to make sure that there's no sort of scarring. Probably neuropsychologic testing, that maybe help us give us idea of what kind of deficits is the person having, and is that particularly consistent with a medication pattern or a seizure pattern or something else altogether. Yes?
You mentioned 2 hospitals have the MEG test in the area. What are those 2 tests?
So Texas Children's has the MEG scanner, and it's shared between the adult side and the pediatric side, and then Memorial Hermann also has one as well, and they share it with the adult and pediatric side. However, having said that, other hospitals in the area refer patients to both of those sites. So it's not, so just because there's the MEG scanner is only at those 2 locations doesn't mean that no one else in the city can have access to it, or frankly in the state can have access to it. And so we frequently see patients from Methodist or other sites that are referred there.
What's the adult side of Texas?
So St. Luke's, Baylor College of Medicine, and St. Luke's. Yeah, sure.
Okay, if you have multiple surgeries, say 4, each surgery can cause scarring, and
Potentially.
scarring can cause seizures. Now, would that cause new seizures?
It's certainly possible. It's very unlikely. So in theory, it makes sense. We're causing a scar by removing a site of seizure focus. Is it possible that the scarring itself will cause a new site of seizures or additional seizures? And truthfully, we don't see that very often. I think what's more likely is just trying to understand what's the underlying cause of the seizures. Is it something that's actually going to be readily treated with surgery? And so if it's not, then maybe you do multiple surgeries and you don't have a response. Or maybe it's a different type of cause of those seizures that we have to look into a little bit more. Maybe it's autoimmune causes or something else altogether. Yes?
If you have had an MRI already and you're admitted to an epileptic center, do they start over? Do they use that MRI as a whole new ballgame?
Great question. So one of the things I tell everyone that I see in clinic is if they've had a prior workup somewhere else, unless I see the images myself, I'm going to throw it out. I don't care about reports. I want the images. It's been too often that I've seen reports that suggest it's normal or abnormal, anything on the sun, and you actually look at the study yourself and you say, wait a minute, I'm not sure I believe that. And so I have to see the images. And that actually goes for the EEG as well. So if someone has had a prior workup somewhere else and they come over to me, I want to see the raw data. I want to confirm it myself. If I don't, then I'm liable to repeat it. I hate repeating things, it's unnecessary, but I have to be able to make sure that the quality is appropriate for the type of patient I'm trying to treat. Other questions? Thank you.
All right, thank you, Dr. Gavvala.